and my respected seniors. On behalf of Indian Fertility Society, IFS SIG Reproductive Endocrinology, in association with UP's chapter, I welcome you to this webinar on reproductive endocrinology. Today, we shall be discussing on two very important topics. One is the poor ovarian reserve, and the second is the idiopathic male hypogonadism. And we have stalwarts of the field who will be enlightening us on this topic. We also have a very engaging panel discussion on the Poseidon criteria, and we look forward to an interesting and engaging discussions today. So I welcome you all again, and for further proceedings, I invite Dr. Piki ma'am, who is the convener IFS SIG Reproductive Endocrinology. Welcome, ma'am.
Thank you, Dr. Varda. So, good evening, everyone. Respected guests of honor, Dr. Abha Majumdar, Dr. K.D. Nair, distinguished faculty, esteemed chairpersons, I can see Professor Vinita Das and Dr. Geeta Khanna amongst all the others. We have very eminent speakers for today, Dr. Kuldeep Jain, who is the founder, secretary, and past president of IFS, and Dr. Surveen Guman, who is the past secretary and president-elect. My co-conveners, Dr. Divya Agarwal, Secretary, IFS UP East Chapter, who has helped me to organize this important webinar. Dr. Richika Goyal, our co-convener for the reproductive endocrinology, along with Dr. Aarti Kapoor, who is another co-convener. Dear panelists, colleagues, and participants, it gives me immense pleasure to welcome you all for this SIG Reproductive Endocrinology webinar, organized in collaboration with the IFS UP East Chapter. Today's webinar has been curated to provide evidence-based updates for improving day-to-day clinical practice. Our scientific program already Dr. Varda has announced. So it's my privilege now to introduce. I think Dr. Abha ma'am does not need any introduction. She is most popular, and Dr. K.D. Nair also is most popular amongst the IFS fraternity. Ma'am, a very warm official welcome to Dr. Abha, the mentor of SIG Reproductive Endocrinology, ma'am. And we are really lucky to have you as our guide. Ma'am is the Emeritus Consultant Advisor, Center of IVF and Human Reproduction. She's a course director, Fellowship in Reproductive Medicine for DNB. I think she's the pioneer and one of the leading IVF specialists of the country for over 40 years clinical experience. And she has been the founder member, past president of the Indian Fertility Society. I can see a huge list, 7 gold medals, president silver medal, vice chancellor's medal.
That's all right, Vicky. We can cut short and we can start.
Ma'am, 2 minutes. And another very important thing is that other people don't know, and it's not written here. She's an excellent endoscopic surgeon also, and a wonderful human being. She's extremely popular. Ma'am has a group of reproductive medicine, and she's doing hand holding for junior and senior IVF specialists, and she's giving advice for day-to-day challenging cases. So, ma'am, we are really honored to have you here with us, and I request you to give your inspiring address for the gathering.
Thank you, Piki, for the nice, kind words, encouraging words. And I'm very happy that you all are into these digital webinars where we can all learn from each other, because reproduction is one of nature's most remarkable achievements. And hormones are its silent architects. Reproductive endocrinology is the science of understanding these intricate hormonal conversations and then translating them into better care for women and couples seeking to build families. So what you are doing by talking about male infertility, or by the Poseidon group, what to do with poor responders, it is all a physiology. is the language of life and hormones are its words. And I congratulate you all for selecting the topic so carefully for this webinar. Congratulations and best of luck to all my speakers, my colleagues, the panelists who have come prepared to talk to all of us on this topic.
Thank you very much, ma'am. Now it's my privilege to welcome Dr. K.D. Nair, sir, officially. He's an eminent reproductive medicine specialist, distinguished academician, and a respected leader in the field of infertility. Sir is a senior consultant and head of the department of Akanksha IVF Center. He is the past president of IFS, and I think sir has got all the medals, awards. I keep on seeing on the WhatsApp group. Every year, sir is, I don't know how he's having so many scientific presentations, 27 international presentations in ASRM meetings, 25 international presentations in ESHRE meetings, Lifetime Achievement Award, Foxy Achiever Award, IMA Janakpuri Lifetime Award, ISAR Lifetime Award. And I have had the opportunity to work with Dr. K.D. Nair, sir, and he's one of the most progressive, most aggressive, encouraging mentor we have had. And sir, I'm really grateful to you for all your encouragement, for your guidance. And I'm very happy to announce here, can you go to the next slide? I'm pleased to announce that under his guidance, along with Dr. Surveen, we had worked very hard to develop the guidelines of IFS. I have been involved in forming number of guidelines for Foxy, Dipsy, and others. But I think we really learned a lot through this procedure, and it took a lot of time and pain. Thank you very much, sir. And it has been just published in the July edition of the Fertility and Fertility and Research Journal. Sir, we are truly honored to have you here with us today and look forward for your valuable words of wisdom.
Thank you, Dr. Picky. Actually, it has been my pleasure to work with this excellent team for developing the guideline, which almost took us 2 years. And I'm very happy that it has been published earlier in IFS Journal, Global Reproductive Health. Now it has been published in Fertility Science and Research. And this has been published in 2024. Maybe after 24, few new things have come up, which we might listen in this webinar. Dr. Suveen Kumar was the co-chair with me for developing the guideline. She is going to talk about the POR issue in our talk. And we look forward to listening to her and maybe get something updated on this topic. POR is a topic which is always troubling all the infertility specialists. The incidence is almost 9 to 24%, and we really don't know how to go about it. Each of us is having his own thinking, his own methodology. That is why we try to bring a guideline so that we can have some sort of a consensus. And we hope that the guideline will give us some guidance how to go about managing poor responder. Thank you, Dr. Picky. Thank you for inviting me.
Thank you, sir. I sincerely thank all our distinguished faculty, members, moderators, chairpersons, panelists, and all the participants for joining us here, taking out time from your busy schedule. And I now invite Dr. Divya Agarwal, who is the Secretary of IFS UP chapter, to introduce the program for today and take us through the scientific program.
Yeah.
Dr. Divya.
Yeah, thank you, Dr. Picky. First of all, a very good evening to all of you, and respected our Mazumdar ma'am, Dr. K.D. Nair sir, the distinguished guest of honor, respected dear Dr. Picky Saxena, convener of SIG Reproductive Endocrinology, co-convener Dr. Aarti Kapoor and Dr. Ruchika, the esteemed chairpersons, charismatic speakers, Dr. Kuldeep Jain and Dr. Surveen Kumar, distinguished panelists and dear friends and delegates, and who have spared their time to join this webinar. I welcome you all on behalf of IFS Reproductive Chapter East and SIG Reproductive Endocrinology. I welcome you all. The theme for this evening is very relevant to our day-to-day practice. Basically, we will begin with the idiopathic male hypogonadism and Aphrodite criteria, followed by practical recommendations from IFS guidelines on poor ovarian reserve for the IVF clinician. Along with this, we will have an interactive panel discussion on Poseidon patients are we stimulating the smarter, where eminent panelists will share their insights and how to manage the different groups of Poseidon patients and how to stimulate them smartly so that we can have a very good IVF outcome. I sincerely thank our mentor, Dr. Abha Mazumdar, convener, Dr. Piki Saxena, co-conveners, Dr. Ruchika and Dr. Arti, and the entire SIG Reproductive Endocrinology team for their support in organizing this academic activity. I would sincerely thank all the participants, all the faculties, and all the delegates for sparing in time and making this webinar successful. Thank you so much. Now, I hand over to our Master of Ceremony, Dr. Varda Arora. Dr. Varda is also the Joint Secretary of IFS East UP, and I would invite Dr. Varda for the further proceedings.
Dr. Varda, you are muted.
You have to unmute yourself.
Sorry. Slide.
और एक ना
Thank you,
आपकी
Divya ma'am.
your photograph is coming over the slides, so if you can just remove that, it is coming over the slides, so there will be problem in the presentation. वो
My
अलग
photograph,
से ना
ma'am?
हाँ
स्लाइड के ऊपर आ रही है,
स्लाइड के ऊपर आ रही है, स्लाइड्स दिखेंगे नहीं अब
या
साइंटिफिक
तो आप थोड़ी खिसकी है उधर की तरफ,
अभी भी नहीं आ रही है मैम।
बिल्कुल
ना,
ऊपर आ रही है स्लाइड्स के ऊपर,
एक कोना कट जा रहा है स्लाइड का।
Ma'am, just let me check.
I think when Varda will stop sharing, I think
Yeah.
it will disappear. I think so.
Maybe
Some might be that when I stop sharing, then it will go
okay,
away.
let's hope. Let's hope.
Yes.
Yeah. If doesn't go, then Karan, you can just check. I don't know how to fix it.
You can continue, Varda.
कोई बात नहीं, you continue. We'll see next.
Okay, we just take blessings and salutations to the light of the Lamb, which brings auspiciousness and good health and prosperity. And with this, we move on to the first session, which is on the idiopathic male hypogonadism, understanding the Aphrodite criteria. And for that, I invite the respected chairperson, Professor Vinita Das, ma'am. She's the director of Gynae Apollo Medics Lucknow, and she needs no introduction. She is the famous and the teacher of teachers for every one of us. And I also welcome Dr. Renu Makkar, ma'am. She's practicing obstetrician, gynecologist, laparoscopic surgeon. She's the director of Makkar IVF Center, Lucknow. Welcome, ma'am. I welcome Dr. Namita Chandra, ma'am, who is active. She is a dynamic practitioner in Lucknow, and she is presently She's presently heading the Department of IVF at T.S. Mishra Medical College. Welcome, ma'am. Now, I also welcome Dr. Vishali Jain. She's the director and founder, Diva IVF and Fertility Center. Welcome, Dr. Vishali. Now, I request the chairpersons to kindly introduce and welcome the speaker, Dr. Kuldeep Jain, sir.
Please share the slide of Dr. Kuldeep.
Kuldeep Jain. Yes. Dr. Vinita.
Yeah,
Dr.
good evening.
Are you here?
Yeah, ma'am. Yeah.
Okay. Good evening, everybody. I'm Dr. Namita. Can you all hear me?
Yeah.
So, welcome to Dr. Kuldeep Jain as the speaker for this session. And I've been looking forward to listen to this talk on Aphrodite criteria. So he's the founder, secretary, and past president of IFS. Currently, he's the member, board of director, and he's been the board of director of IFS and member scientific committee. And he's the recipient of Lifetime Achievement Award in IFS, ISAR, Hope, and VOH. So welcome, Dr. Kuldeep Jain.
Vardha, you have to stop sharing.
Yeah, I'll stop share now. Sir, you may start sharing your slide. Is it okay now?
Yes.
Okay.
Thank you, everyone, and congratulations to this group
Welcome, sir.
steered
Welcome.
by Dr. Picky and the whole team of UP chapter. It is really wonderful to be part of this webinar. Can you see my screen? Can
It's
you see
just
my
coming,
screen?
sir. आ रही है, sir, आ रही है. दो.
Okay.
Yes, sir.
Yes.
Okay, so today's topic is
Sir, make it full screen, please.
Sir,
I have
sir,
made
please
it.
do the slide share.
It is in slide share only now.
No, sir.
फुल स्क्रीन वाला बटन दबा दीजिए तो फुल स्क्रीन हो जाएगा.
सर स्लाइड शेयर वाला नीचे कर दीजिए आप.
हाँ,
स्लाइड
नीचे
शेयर में आ
slide.
जाएगा.
Yes, sir.
वैसे वो.
On the
सर एक बार फिर से बंद करके दोबारा स्टॉप शेयर करके ना कर लीजिए, शायद फिर आ जाए.
अभी आ रहा है?
नहीं सर, उसको बस
Sir,
स्लाइड
नहीं.
शो करना होगा. ये जो बटन है
नीचे.
एकदम नीचे, लोएस्ट बटन सर.
Karan, will you help, sir?
मुकुल इज देयर.
Mukul,
यस
sorry.
सर
Mukul.
आपको एक नीचे बटन दिख रहा होगा कमेंट्स के साइड में ही, रीडिंग मोड के साइड में.
अच्छा, इसके जस्ट आगे राइट साइड पे, राइट साइड.
ये वाला बटन सर कर दीजिए. ये
हाँ सर, एकदम नीचे.
Which one?
सर द लोएस्ट रो,
सबसे नीचे, sir.
square type of button. Yeah.
Can you see my
Please
screen?
guide. We can see the screen, but it's
Sir,
not
it's
there.
quite
Full screen
small.
is
It's
not
not
there.
coming full screen, na?
Full screen is not there.
उतना मजा नहीं आएगा.
कल 10 बजे से लेके 5 बजे के बीच में सुबह सुबह ही तुम चले जाना. 10 बजे चले जाना. मैं तुम्हें उनका नंबर व्हाट्सएप.
Now, can you see my screen?
So we can see the screen, but still the slideshow is not there. Yeah. This is the button you have.
Yes, sir.
Yeah.
Yes,
The lower.
yes.
Yes.
Now, can you?
Yeah.
Yeah.
Yes, sir.
Okay, so sorry for this trouble. I bring greetings from my center, KJIVF, where I'm working for last 25 years. So today's topic is we are looking beyond semen analysis in this talk. And this is something which has come very recently, and most of the people are not aware what is it. And those who have listened and gone through Aphrodite criteria, either they are finding it too difficult to understand, or they are thinking that this is something which is going to solve all the problems. So in next 20 minutes, I am going to just take a deep dive into this Aphrodite criteria, and we'll try to understand what is it. So just a small background through this paper. Infertility is actually historically received, male infertility has received less attention when you compare with the female infertility. There are a lot of gaps in understanding the male partner, and our all investigation, all treatment, they revolve around semen analysis only. And whatever report we are getting from labs, different labs, we are making them as a tool to treat the male partner. So that is what is happening currently. And Aphrodite criteria, which was introduced in very recently in 2024, they have looked the male infertility factor in a different light. This was a landmark paper actually by Sandro and his group, and they tried to assess the management through a different angle. Till now, we have been classifying the male factor infertility according to the causes of male factor infertility and treating them. This group looked at different perspective, that is the hormonal changes in male infertility, and they had devised some criteria. All are not actually fitting into the picture, and it is giving a half picture of the whole problem. So we will discuss that how it is working. So today's agenda is we will look in the gaps in male infertility management. We'll look what is Aphrodite criteria. Are we reinventing the wheel? How it is different from current practice? Does it provide a definitive and productive approach? Or is it backed by evidence? And what are the debates, limitations, and way forward? This is the classification which everybody knows about the male. There is hypogonadotropic hypogonadism, which is very minimal, 1 to 2%. Most of the patient is from eugonadotropic hypogonadism, and Aphrodite criteria is basically looking only at this group, with some of the other groups are included into into this. 10 to 20% are basically post-testicular causes, and 10 to 15% are hypogonadotropic. And the option B, according to this the classification, we are giving at present medically 5 to 7%, surgically another 10%, and most of the patients, they are going for ART, that is more than 90%, along with combined therapy. And this is the normal chart which everybody is using. When you get a abnormal semen, you go for the ultrasound, get a varicocele, you advise varicocelectomy. When you find very low FSH or testosterone, you give hormonal treatment. When you find infection in the semen group, you give the antibiotics. And if these patients, they do not conceive, then you advise IUI, or in most cases ICSI. So that is how the current practice is going on. And this is happening because there are a lot of gaps. If you compare this scenario with female infertility, when you are having a hypo female, you are having a definitive answer. In hypo male also, you are having a definitive answer. And this is the only area where you are having some definitive answer. Rest of the male factor, there is no research and no guidelines available how to go about, like testicular failure in males, you don't have much. Hypo in males, you don't have much. Idiopathic infertility male, you don't have much. You can go for IUI, you can go for IVF, you can continue giving medication, you can continue giving hormonal injection. And when it comes to unexplained infertility, when everything is normal and patient is still not conceiving, then you don't have any clue. Debates are all a part of our profession. It could be monkeypox or it could be acne. And that is happening with the male factor also. Now, what is Aphrodite? Actually, it is a Greek goddess of love and beauty. It is the female counterpart of Poseidon, which is the male god for women's fertility. And from there, the Aphrodite criteria, it is taken from there, but it is actually not related to the goddess. So what Aphrodite criteria is looking at, the framework is we are looking beyond assisted reproduction. At present, what is happening, if there is any patient who is having moderate severe male factor, we just don't investigate that patient and we just go either offer IUI or IVF-XC. So that framework is changing using this criteria. The diagnostic pillars are taken: clinical history, semen analysis, and serum FSH and testosterone. So this is only these three criteria are used in Aphrodite criteria, and on the basis of the clinical history, semen analysis, and serum FSH and testosterone, there is a stratification happened, and targeted therapy is advised. So there are 5 groups. Clinical goal of these criteria is unlocking the latent testicular potential. So what they have suggested that in all groups of male infertility, whether it is group 1 or group 5, there is a role of hormonal treatment before moving on to the ART treatment. So that is the area where they are looking at. And it aims to improve sperm quality and quantity in both natural and assisted conception. So there is a clear-cut BAB design pattern. There is a standardized patient management. It provides a better understanding of the prevalence. It helps researchers to discover new pharmacological intervention, facilitating communication between the clinician, researchers, and patient, and allow for comparison between treatments and outcome. This is what is happening. We are having FSH, which is working on Sertoli cell, LH on Leydig cell. That is producing testosterone and that is stimulating the spermatogenesis. So these 2 or 3 hormones have been playing in male factor infertility. Now LH is activating basically Leydig cell. FSH powers the Sertoli cell, and because of the action of these 2 hormones, especially LH, there is increase in the intratesticular testosterone, which leads to the synergy of spermatogenesis. So it is very easy to understand how the spermatogenesis is being affected. Now, how it is to be used? We have to evaluate 3 clinical markers, which I already told. On the basis of the report, we divide whole group of the idiopathic hypogonadism into 5 groups. Transition from empirical, so all these patients, they are getting some empirical form of treatment, and here we are going for a targeted therapy. Role of andrologist is coming more than the ART specialist if you are using Aphrodite criteria, and I think this is the main area where we need to discuss how much we can depend on this Aphrodite criteria before moving on to the ART specialist, because there are a lot of debates, a lot of limitation of these criteria we are going to discuss in next few slides. So if you want to understand, there is a production failure and not there is physical blockage. So all patients who are having a blockade, they are moved away from using these criteria. That is one important aspect, that you are not dealing with the physical blockage. Only those patients who are having production failure can be benefited using Aphrodite criteria. So you need to conduct a detailed physical examination. You get a profile, FSH, LH, and TT ratio, and AMH also. This is one area, again, this is a newer area where the role of AMH I will be discussing. Using these criteria, they have said that retrieval success rate can be increased when you are doing micro TC. So this is AMH paradox. In non-obstructive agiospermia, a biological production failure is occurring, and AMH is taken as a specific marker according to this criteria. AMH and testosterone, they have taken the AMH and testosterone ratio in deciding whether the patient of NOA is going to be successful for the retrieval or not. So if you are having a high AMH in male patient, there is less chances of getting a mature sperm, according to the theory provided by Aphrodite criteria. And when you are having low AMH, the Sertoli cells are maturing better and resulting into the probably high chances of getting a successful sperm retrieval. And when this is taken along with the total testosterone, then the ratio should not be more than 1.02. So if the AMH and total testosterone ratio is less than 1.02, then there is a very high chance of getting a sperm from non-obstructive agiospermia. This is something which we have been not practicing till now. And this is one area where we need to generate more and more data, doing AMH, doing the total testosterone, and if the ratio we find, and then we have to compare in the real case scenario, because there are not many studies which have used this criteria in and correlated with the retrieval. Typical reference range for your reference AMH in male anywhere from 1.8 to 7.5 nm is taken as normal, and in non-obstructive agiospermia, we expect it to be significantly low. Mind you, significantly low level of AMH are found in non-obstructive agiospermia. Same is with inhibin B. It is highly suppressed. However, 17 OHP, they have not taken OHP as a marker. Only AMH and total testosterone is taken to get the idea whether you are going to get a sperm in surgical retrieval. Now, I am not going into the detail of various methods. Everybody knows you can go for a TESE or micro and try to get the sperm. And once the sperms are available, they can be used for your ICSI procedure. So that is the normal procedure. How Aphrodite criteria is helping in this scenario of getting sperm. One is the use of markers, and second is use of FSH even in hypergonadotropic hypogonadism. They have suggested that you can boost the maturation by giving FSH in these cases. So that is something which is very, very debatable. We will discuss. Aphrodite criteria are presented as a magic box, but it is not so. Till now, we have been doing empirical guesswork, and by using Aphrodite criteria, we have divided them into 5 distinct groups. It is a type of precision diagnostic guide for enhancing the natural and assisted conception. And this is going to help in the research area probably more. Regarding the hypogonadotropic hypogonadism, there is no debate. That is one group, which is everybody knows that this is the group where the gonadotropin treatment regime is justified, and everybody is practicing that. And take-home rate, either by hormonal therapy or combining it with ART, is more than 90%. So this is the only group where there is agreement between the current practice and proposed practice. This is one paper which is already highlighted the use of gonadotropin in hypogonadotropic hypogonadism and providing the success rate. Our center also, we have been doing a lot of studies and we analyze our data of hypogonadotropic hypogonadism. You can see 90% were azoospermic and there was significant improvement in seminal parameters when we used gonadotropins from between 3 to 6 months, and 14% even conceived spontaneously. So Aphrodite 2 criteria, that was Aphrodite 1. So in Aphrodite 2, what is happening? This is the group oligospermia, where you find count less than 16 million. This group represent idiopathic infertility with low sperm count, normal FSH and testosterone. So here they have taken the FSH is normal and testosterone is low. Now, beyond Simon report, if you see FSH and total testosterone, then this is basically the functional hypogonadism. We are not talking of permanent damage here. But in these cases where the count is normal and hormonal milieu is normal, there, if you can give the monotherapy with FSH, then they have suggested a improvement. Now, this is a very, very, very debatable area. We have been using gonadal therapy only in those cases where you are having hypogonadism. In those cases where FSH and LH is normal, testosterone is normal, suggestion of giving FSH therapy, you need to provide the evidence. But here they have suggested that this is the group where mono FSH therapy may be justified. Normal hormones, lowered semen parameters, 50 to 60% patients are belonging to this group. So if we start giving hormonal therapy as suggested by Aphrodite criteria, that might be a problem until unless we are able to produce the data. And there is a need using these criteria if you are giving FSH to these patients where FSH is already normal. Whether it is useful or not, what they have said, it actually boosts the latent testicular reserve. That is how it is going to work. So there is a paradigm shift in this group, actively treating for natural and assisted conception. Now coming on to Aphrodite 3 criteria, where there is biochemical hypogonadism. It is characterized by lower semen parameter, normal serum FSH, and reduced total testosterone. And cutoff of total testosterone is below 350 nanogram. Suggested regime is a combination of SCG and FSH. So here again, if we are looking at the testosterone, only SCG should have been advised. But here the suggested regime is basically FSH and SCG. This is a paper very recently, what is happening in daily practice. And this paper suggested that there may be a role of SCG plus FSH in Aphrodite 3 criteria. So this is first paper which came out after Aphrodite criteria. We need more and more evidences before we put it into the practice. Aphrodite 4, if you see here, it is hypergonadotropic profile. file. Most of them are presenting non-obstructive azoospermia. FSH is high. Testosterone is normal or reduced. Now, in these cases, but Aphrodite criteria is suggesting priming with SCG and FSH. Now, SCG might stimulate Leydig and Sertoli cell, and if FSH is also added, then using these criteria and these theory, they have projected that we might improve the chances of getting the sperm recovery by giving hormonal therapy. Now, this is again under bracket. Last one is again a very, very different group where everything is not, it is unexplained fertility. Sim parameter are normal FSH, normal testosterone, and in that group also the suggestion is stimulatory approach using FSH to boost the spermatogenesis beyond its baseline. Now, how justified it is a food for thought. So, when you are looking at the Aphrodite criteria, there is a stratification. So, how much is the justification using these Aphrodite criteria in clinical practice, we need to see. So, debate continues here. And many people, they have suggested or they have criticized these Aphrodite criteria because are we reinventing the wheel? If you remember your practice before the advent of intracytoplasmic sperm injection, what was the treatment? Everybody was getting either clomiphene or gonadotropin. Okay, and that practice was withdrawn after the invent of intracytoplasmic sperm injection. The practice of giving gonadotropin to all patients of male infertility was stopped. And now again we are suggesting that all patients, whether it is normogonadotropic male infertility or unexplained infertility or a hypergonadotropic infertility, there is a role of gonadotropin. So this is the main debate when we discuss the Aphrodite criteria. So is it a dangerous leap forward, exposing critical scientific flaws in patient risk? Now, marketing over evidence-based medicine. Many people have commented on that. It is a drive which will promote gonadotropin use unnecessarily in those patients who are not going to be benefited. Where is the evidence? So we need to generate evidence if we really want to see the effect. We have already seen the effect of use of gonadotropin 20 years back. Now we have stopped. So if there is anything really it is useful, then we need to generate the evidence. There is heavy physical and financial burden of gonadotropin therapy that we need to keep in mind. It is a dangerous cookbook approach to infertility. Rigid protocol encourages clinicians to ignore root cause like lifestyle, toxins, and genetic anomalies. There is no talk of these factors in male infertility when we are using Aphrodite criteria. So we should not look for these factors and treat them. And there will be artificial delays. The patient requiring ART, you are giving gonadotropin therapy, how much it is justified, we need to relook. So what is the solution? Now, stratifying is fine. You are stratifying, trying to find out a hypogonadotropic patient. If you see criteria, group 1 and 3 may still be justified using gonadotropin. But when it comes to 2, 3, 2, 4, and 5, you need to generate the evidence and then only you can start. Like hypergonadotropic patients, where the FSH is already higher, if you are giving 3 months or 6 month treatment to these patients, how much benefit you are going to get, that needs to be justified. So Aphrodite is basically targeting the root of male infertility. Old approach is bypassing all these routes and directly going for the ART treatment, while Aphrodite criteria suggests you have to go from step 1 to 2, 3, 4, and then go for ART. Now, this is the precision hormonal diagnosis and prognosis, NOA versus normal hormonal signals. This we have already discussed. Low AMH, higher retrieval of success, and when the AMH and total testosterone ratio is less than 1.2, it may be better for the retrieval. So this is one area which I really feel we should use in practice and generate the data, how much is it is going to give the impact we need to see. So AMH testosterone favorable ratio is 1.02, and it can predict accuracy of positive retrieval up to 95%. That is what is claimed, but we are not having much data, so we need to generate the data. So, dear friends, I have tried to critically analyze Aphrodite criteria basically, because whenever anything new comes, we just start using that in practice. I think we need to have a different approach here. There are few good things of Aphrodite criteria. We need to take them into current clinical practice, but rest of the areas where there is a debate, we need to generate more evidences before starting in the clinical practice. If you see major guidelines, whether it is coming from AU, AUA or SRA or SRM, they have not taken up the Aphrodite criteria into the guidelines. And why they have not taken up? Because it is a new frontier requiring large-scale validation to move beyond empirical treatment. There is limited evidence for a specific patient group, especially 4 and 5. Conflict with the existing global guidelines remains, yet there is lack of early treatment response marker, empirical rather than evidence-based threshold. So whatever threshold they have given, they are all empirical. There is no evidence-based, and there is restricted scope of diagnostic application. So finally, it is an important step towards precision medicine in male infertility, because now this is era of precision medicine and male infertility. This is the one area where you can precisely prescribe hormonal therapy to the patient, which can be benefited. But at present, Aphrodite should be viewed as a promising clinical and research framework rather than a definitive standard of care. So that is my final comment on Aphrodite criteria. You have to choose. You want action alone or you want action with purpose. Finally, when the evidence is produced, you can put a nail. But till now, the scenario is debatable. I acknowledge Dr. Pankaj Talwar for providing some of the beautiful slides which I have used in my presentation. So thank you, Pankaj. And thank you everyone for listening to this talk. Thank you. I am open to question.
So there are a few questions in the chat box.
Yes.
One is that in patients with sperm count less than more than 10 million, but less than 16 million, does testosterone and FSH test needs to be done?
Yes, according to Aphrodite criteria, the hormones they have suggested is FSH, testosterone, and AMH also. Especially AMH comes when you are dealing with non-obstructive azoospermia, but for all other patients, clinical parameters, FSH, and testosterone needs to be done, so you can divide your patient into a definite category.
Also, one more question is that can we give HMG instead of FSH, and till how long we should give FSH and HCG?
In hypogonadotropic hypogonadism, the treatment strategy is simple. If the LH is very low, then SCG, you start with SCG and then combine it with HMG. That is because their FSH and LH both are low. Okay. So you start with SCG and then combine it with HMG. But in those cases where the hormonal profile is normal, because Aphrodite criteria is suggesting a group where the hormonal profile is normal, I don't suggest any gonadotropin. In those cases where the testosterone low, you can start with SCG rather than going for FSH. And then once the Sertoli cell, this Leydig cell is active, then you can boost Sertoli cell activity with FSH. So here you have to combine SCG and FSH, not LH.
Any more inputs from any questions from the chairpersons?
Thanks a lot, sir. It is always a pleasure to hear from you. And such a difficult topic and a new topic, you have made it very simplified. And now we can use our judgment to use this criteria in clinical practice. One question is, sir, are you using this criteria in your clinical practice?
No, I am critically analyzing this criteria at present. I have not put in practice. What I am going to use, AMH as a marker, because we are not having many markers in NOA. So I am going to use two arms where the AMH is not done, and that is what we have been doing, and other arm where AMH and testosterone is being used as a marker, and then we can compare and we can generate that data. So my strategy will be generating the data using the stratification advised by Aphrodite criteria, because that is the need of our.
Congratulations, Dr. Kuldeep. It was a very informative talk. Definitely for infertility specialist, getting the AMH and testosterone routinely done in cases of male infertility will be a new aspect of dealing with the male infertility. And before just jumping to stratify the patients on Aphrodite criteria, we should first generate the evidence, and then based, as Vaishali said, based on the judgment, when to use FSH or when to use HMG or whether to start with SCG. I think it is a very methodical, depending on which hormone is less and what is happening in the body, one can start. The time will tell how we are going to use Aphrodite criteria and managing the male infertility. Thank you so much.
Yeah.
So my question is, you are doing AMH, like if the count is less than 15 million, or azoospermia, only in azoospermia we have to do the AMH.
Yeah. It is a marker for non-obstructive azoospermia.
Okay, so if a count is less than 15 million, we need not to do it.
Need not to
Only
do.
in
Need not-
azo. Okay,
Yeah,
okay.
need not to do.
So I have a comment, very nice lecture.
Yeah, I mean,
I am wondering whether we should give cyphine to all patients, but because that's an indirect way of increasing FSH. And they've literally said that all male infertility needs FSH.
yes.
So do
that is
we have to
that
give
is yeah,
injectable?
that is what
There should be some study on that, no?
yeah. Yeah, so actually, because this is reinventing the wheel. Before, if you remember 20 years, I remember I used to give a lot of gonadotropins to all male because there was nothing.
Yeah.
And again, it is being suggested. We have already seen that nothing was happening. But yes, evidence you have to generate. You have to really compare the effect of not giving gonadotropin and giving gonadotropin.
And giving clomiphene. And giving clomiphene instead of
Clomiphene
Yes,
or
yes, yes.
even letrozole these days, ma'am. Some of the papers are suggesting that even giving letrozole may increase the FSH.
Yeah.
No,
So I think
that's why the first comment from one group is coming that it is market driven.
yes,
It is boosting the gonadotropin market.
gonadotropin
Yes,
Yes.
industry.
yes.
So that is see who if you look at the group, there are a lot of andrologists. Okay. So it should not basically become a comparison between the andrologist and ART specialist. As a clinician, we should balance the scenario. That is what is my suggestion. We need to see from the patient perspective whether we are doing some good, yes. If we are doing harm, no. Means that criteria has to be taken when we are using these criteria.
One more point, sir. Has this FSH and all got a regulatory approval for all these 5 groups and all? That also needs to be seen. And the pharma companies should do clinical trials.
No, pharma companies
Well-powered
don't leave
clinical
everything on
trials.
pharma company. It is a clinician which should do the trial, and that's why my last slide is it is not the standard care. It is a experimental framework. One should use the experimental framework and generate the data and decide whether it has to come to standard care or not.
Sir, regulatory approval ke bina clinicians, we will not get ethical clearance. We may be
No,
doing more harm.
see,
So we have to take
FSH is approved for the HRT for male infertility. So there is
not
no.
for high FSH group, sir.
Yeah. So you have to
Hyper,
generate
as
the
you
data.
yourself said,
You have to generate the data.
hyperandrogenic and all those.
You have
So
to generate the data.
So wonderful lecture, Dr. Kuldeep, and you have given
Thank
a
you,
lot of,
Geeta.
you infused a lot of
excellent, sir. Very nice talk.
food for thought, how we can go and approach and do it in our clinic and see the results and then pull up the results and discuss with each other and go further how we can use this Aphrodite criteria.
Thank you. Thank you.
Yeah.
Thank you for the comment. Thanks.
Sir, I have a question that earlier we used to give clomiphene in patients who had either in patients of oligospermia who had either normal or low FSH and with low testosterone. Testosterone was less, like less than 350. So
Siphene will not work. Siphene will not work if the testosterone is less because it is not sensitized. So that's why that group, the prescribing of SCG is justified. Prescribing of SCG is justified in that group if the testosterone is low. So that is there are few good things about this criteria. They have suggested that you do total testosterone. We are not doing normally. Okay. We are stopping at FSH and LH. Just to so I think there are few good things about Aphrodite criteria, and we should take them into our practice.
thank you so much, sir.
Yeah.
With this, we move to the second session of today's webinar, which is on IFS guidelines on poor ovarian reserve, practical recommendations for the IVF clinician. And may I take the honor to invite the respected chairpersons, Dr. Geeta Khanna, ma'am. She's the National Advisor, Indian Fertility Society, and a very beloved teacher of us in Lucknow. Welcome, ma'am.
Thank
Dr.
you.
Sunita Chandra, ma'am. She's also the advisory board member of IFS UP's chapter and a very dynamic IVF specialist of Lucknow. Welcome, Dr. Sunita Chandra, ma'am. Dr. Usha Yadav, ma'am. She's a very active member of our UP East chapter, a senior consultant, Octavia Hospital, visiting consultant, Navjeevan Hospital, Varanasi. Welcome, Dr. Usha Yadav, ma'am. And Dr. Pragya Pandey, she's the founder director, Pragya Mother and Child Care and IVF Center from Varanasi. Welcome, Dr. Pragya. Now I request the respected chairpersons to please invite and introduce the speaker.
So welcome, Dr. Sabine Guman. Seeing you after a long time.
Yeah.
And you are a legend in yourself. I had been working under you when you were the secretary. And in and out.
We have been working together.
Yeah. So, and she has a 37 years of clinical experience, authored lot of books and publications. She's program director for fellowship in reproductive medicine at Max Hospital, past executive editor, Fertility Science and Research Center, co-chair IFS guidelines on POR, then co-chair IFS consensus guidelines on psychosocial care in ART, and holds a lot of positions, academic societies, like Indian Fertility President-elect, Senior Vice President, Secretary.
Thank you, Dr. Geeta. Thank you. Thank you so much for your kind words.
I invite you now, and please
Dr.
proceed.
Vartha, please stop sharing your screen. Yeah.
Yeah.
Welcome, ma'am. You are the person who had made the guidelines along with sir.
Yeah.
So it will be a pleasure to have them revised again.
They're very dear to my heart. It was when
Yes.
I became the secretary, that was the one thing I wanted to do. And
Yes.
I think sir supported me on that. So, thank you, first of all, IFS SIG Reproductive Endocrinology, Picky, and our whole team. And thank you, UP East Chapter, Divya, and Ruchika, and Aarti for having me over. So, I am going
Ma'am, will you make it slideshow, please?
I'll do that. So, I'm going to be discussing the guidelines, but what I'm going to do is I'm first going to go over the practical recommendations and mention what the guidelines say, and in the end, I'm going to summarize the guidelines. So we all know what POR is. We know what Poseidon is. We know Group 1, Group 2 is the unexpected poor responder, young and old, and Group 3 and Group 4 are the expected poor responders. And this has now become a patient-oriented strategy because we all want one euploid embryo which is going to help us irrespective of the woman's age. So two things came out of the Poseidon criteria. One was the follicle output rate. The follicle output rate measures the consistency between the pool of antral follicles at the beginning and the number of actual follicles which responded. And the follicle to oocyte index is the antral follicle count versus the actual number of oocytes which you retrieved. And anything less than 50% is a hypo-response. And now they say the terminology poor responder should not be used, a hyper-response should be used. So now in 2016, the Poseidon was introduced as a new marker of success. And the main thing it concentrated on was to be able to retrieve oocytes to give a euploid embryo, which is the logical endpoint to guide any clinician when they are doing a stimulation, making it an individualized approach. And why is a euploid embryo important across ages? Because it totally changes the fate of the elderly women. Any euploid embryo will give you a 50 to 60% success rate. It will implant irrespective of whether it is from a 25-year-old woman or it is from a 40-year-old woman. That's how age just goes, becomes irrelevant. How does number of oocytes become important? Because the more the number of oocytes, the higher the probability of getting that one euploid blastocyst. And if you look at the ART calculator, it says that age, expected aneuploidy rate, fertilization rate, blastocyst formation rate, and total number of oocytes is what is required for calculating. So in a younger woman, maybe that euploid embryo would come in 4 to 7 oocytes. In an older one, she may require 12 oocytes. So how is the success related to the number? Now, when you look at this chart, you look on this side is the probability of having at least one live birth. And on the x-axis is the number of eggs frozen. So if you look at 20 eggs frozen and you look at the age over 40, 42 to 44, well, you have only a 10% probability of having a live birth with 20 eggs frozen. But when you look at this age under 30, this probability becomes 90 to 95%. And that is how age changes. And here I'd like to mention that this whole scenario goes for a 6 if you have that one euploid embryo. Then you are good whether you're 40 or you're 35. Now, what are the reasons for a hyporesponse in a patient? It could be genetic or environmental causes. We'll come to that. It could be asynchronous follicular development. I think all those who stimulate have been faced with this particular thing of a asynchronous follicular development, especially in an antagonist cycle. Some are small, some are big. It could be a low gonadotrophin dose, and it could be technical issues involving triggering for the final oocyte maturation and oocyte pickup. Now, the first step in stimulation of POR is to predict the chance of conceiving, which is dependent on the woman's age and the number of oocytes retrieved. Now, what causes a hyperresponse? Let's come on to the genetic causes. We know that they are variants, the LH gene polymorphism and the FSH receptor polymorphism. Both of them are associated with a poor response and a higher dose required for stimulation. So in a homozygous carrier, it is 3,500. In a heterozygous, 2,200. And it is much more than that with a non-carrier. So comes the pharmacogenetic approach. And here I'd like to mention that the IFS guidelines say that routinely nobody should be tested for these genes. It's only when there's an indication and you feel it's present, it should be done. So what are strategies to individualize the stimulation protocol here? There are 5 main strategies. One, we go for a recombinant FSH because it has a higher biopotency and a higher number of oocytes. We increase the dose of FSH, or we add a recombinant LH, we add adjuvants, or we do a dual stimulation. So let's take these as they come. So now when you look, group 1, group 2, and group 3. Group 3 is the normal group. And if you look at the dose of FSH required for the stimulation and for the peak estradiol, you will see that the group which is affected by the FSH polymorphism, if you give a higher dose, 225 instead of 150, you reach the same level of estradiol as those who do not have a polymorphism. So increasing the FSH dose is one of the methods of tackling this. And the IFS guidelines recommends it if there is a genetic cause like this. How much should the dose be increased? So this was evaluated and they found that a dose increment of at least 50 IU of the initial recombinant FSH dose would lead to 1 more oocyte. So when they increased the dose in these 160 women, they found that statistically significant higher quality embryos in number were achieved. Now we come to the role of LH. So it was recombinant FSH, then it was raising the dose of FSH. Now it's the role of LH. We all know LH works under a therapeutic window of an LH threshold and a LH seal. So too much LH is going to cause a problem, cause atresia. Too little may lead to a hyperresponse. So we need to identify which are the women who require LH. One is, of course, those deeply suppressed endogenously. That could be a hypo, it could be an agonist or an antagonist. 20 to 30% of women who are not deeply suppressed are normal women, have less sensitive ovaries. And which are these women? The older patients and the poor or slow hyperresponders. Often you are, stimulating and the follicles are not going beyond 10. These are hyporesponders. Or instead of 10 follicles stimulating, only 4 have stimulated. So these are the ones which you could say may respond to LH supplementation. Now, with older women, the evidence is clear that if the woman is under 36 and she has received LH, the odds ratio is just 1. That means it has made no difference to the clinical pregnancy rate. But in a woman of more than 36, it is 1.5 times clinical pregnancy rate on adding an LH. So implantation rate and clinical rate both become more. This particular meta-analysis said that recombinant LH could be beneficial in 2 subgroups. One is the unexpected hyperresponder. That is your, according to the Poseidon, group 2 and group 1. And the second is those between 36 to 39 years of age. So they said that beyond 39, actually LH doesn't help and nothing helps because the age has taken over. But these women who are gradually becoming older, they have a lower response to LH between 36 and 39, and their LH would be helpful. So now comes the dilemma that should you increase FSH or add LH or do both, or what do you want to do? So very nice multicentric trial. One group was FSH plus LH. Second group was higher FSH. And they found that adding LH was better than increasing the dose of FSH. And same thing was they analyzed in the meta-analysis in 2014, where they said that definitely pregnancy rate is better with adding LH. And this has been recommended by the IFS guidelines. How much LH to add? Well, if you see, there is a transition from 75 to 150. So 150 is what they say you should give in an antagonist cycle. In an agonist cycle where everything is suppressed, with an antagonist, you could add 75. When should it be added? Agonist, it should be added at the start of the cycle because she is deeply suppressed. Antagonist, when you start antagonist, because that's when the suppression of LH occurs. And in the first cycle, wherever you're observing stagnation, that it has for 3 days, it is just lying at 10 to 11 mm. That's the time. Please add LH.
First day.
What about expected poor responders? In expected poor responders, we are going for androgens, DHEA, testosterone, and we go with this logic that it acts at this level of antral follicle and it improves the antral follicle count, increases the androgen deficiency, which is found in all ages, is removed because the DHA helps out. And you see it improves clinical pregnancy rates, the live birth rates, and the aneuploidy rates decreased from 60% to 38%. But it acts more in women of more than 42 compared to the younger women, obviously because the androgens are decreasing at an older age. And it requires at least 2 months for the action to start. So just starting and stimulating is not going to make a difference. And the maximum effect takes place at 6 to 8 months. So that is what you should tell your patients, that continue taking, even if the IVF cycle fails, continue taking for the next cycle. But there are conflicting evidences of DHEA and testosterone. And the latest Cochrane review says that the testosterone is likely to improve the live birth rate and clinical pregnancy rate with pre-treatment, but DHA likely results in little or no difference. DHA and testosterone do not decrease miscarriage rate. Now, this is the latest Cochrane which has come in, where they're saying testosterone improves. IFS guidelines, I'll come to it. They did not recommend it, and I'll come to why. Now, growth hormone. Now, growth hormone, it acts at the recruitment of the primordial follicles. It recruits them into the growing pool, protects the antral follicles from atresia, and increases the sensitivity of the follicle. And you find these growth hormone receptors on the granulosa cells. And if you look at this meta-analysis, it increased the M2, the PN, number of embryos, implantation rate, clinical pregnancy rate. Everything was increased, but it did not improve the live birth rate. And this was a very recent study of 2022. And even the Cochrane review of 2021 says there's an uncertain effect on the live birth rate. But yes, I do in my clinical practice use growth hormone. I give 4 international units and I start at usually the 5th day. There are many people who start on the 1st day. There are some people who even start in luteal phase. But I've seen that giving on the 5th day is good enough. It gives you a good result. Your smaller follicles which have not stimulated, they start coming up. Now, IFS guidelines do not recommend it, and I'll come to that. Then what about asynchronous follicular development? Very, very common in our practice, and we lose out on so many follicles because one follicle has become 20 and the other one is still at 10. So you can give estrogen in the luteal phase. It prevents a premature rise of the FSH, and this premature follicular development is suppressed, and you don't find that big follicle on day 2, which is going to cause a asynchronicity, and it decreases the cancellation rate. Again, not recommended. GnRH antagonist before start of stimulation is another way of synchronizing the follicles, where you can give the E2 patch and the ganirelix together. What about duostim for poor responders? Well, you got only 2 eggs in the first, you can ask her, go in for a second cycle. You do the first ovarian stimulation, trigger with an agonist, second one start after 4 days, and again, let the menstruation come, it doesn't matter. Second trigger is either an HCG or an agonist. The only reason why this is done is that it decreases the dropout rate, or if you've got an international patient who has to go back, in that case, or oncofertility where you need to do things quickly. Now, in otherwise, 2 consecutive cycles are probably equally effective. Are we compromising quality in duostim? No. Luteal phase is as good as follicular phase for stimulation, and you get the same amount of blast and overall euploid rate. The BISTIM study is what I'm quoting, where they say that 2 consecutive cycles or a duostim, there is no difference. So why stress her out with 30 days of injections? You might just do one after the other if you want to pool the eggs. Again, IFS not recommended. And why? So if you look at the SWOT analysis, basically we are stimulating follicles which were never meant to be stimulated. They were in luteal phase, they were never meant to grow and ovulate. So we are going against nature and exploiting the anovulatory waves of the follicular recruitment. And we need to actually undergo a thorough biological and clinical investigation before we start doing this. So again, ESHRE guidelines have said that it should be considered for urgent fertility preservation and used in clinical research context, not as a routine. What about the trigger in POR, which, when, and how much? Well, if you see the studies where they've given a dual trigger and they've given an HCG trigger, and they've seen that the number of oocytes is the same, but the clinical pregnancy rate is nearly 3 times. And this was more so for group 4 of Poseidon. So they say that the dual trigger helps to mature the oocytes better, and the blastocysts are better. And does the dose make a difference? Yes, they did find that in poor responders, those who got a higher dose gave more number of oocytes. So I routinely do give a 500 recombinant HCG. I give it for 2 reasons. One is that yes, a higher dose may make a difference. Second is that I always feel the patient may not take it properly. It may spill, something may happen. I don't want last minute things on the pickup that there was not enough HCG, and that's why the precious oocytes for POR did not come out. When to trigger in POR? So there may be large size follicles, and do they yield us? Like if you have 2 big follicles, 2 small follicles, now are we calculating just a 24 yield us? Well, look at this. It does yield. Recovery rate of oocytes is 64%. Fertilization rate is same, and top quality embryos are 84% in a large sized follicle. While a non-significant decrease in oocyte recovery rate was found, but they found that top quality embryos were there in even large size follicles. What about smaller size? So this was a study where 8 to 12 were seen, 13 to 23, and more than 24. And just look at the oocyte recovery rate. Even in the 8 to 12, you found a good fertilization rate, good blast rate, and a good live birth rate. So always in your practice, once you've taken out all the oocytes, if you're finding follicles which are 10 kindly do the retrieval for them, because you will find oocytes in them, and those oocytes do form blasts. This was a study I conducted with my postgraduate, similar study, and we did find that the smaller oocyte, smaller follicles gave us blastocysts. Now, if you look at these women of higher older age group, this was a study which was conducted in 2018, and they divided it into 13 to 15 mm they triggered at that time, 16 to 18 mm size they triggered, and 18 to 20 mm. The best results were in 16 to 18 mm. So don't wait for them to go beyond 18 and don't trigger too early, but the best results of high quality embryos and pregnancy rate were in the middle group. Converting IVF to IUI, only 2 follicles have formed and you tell her, okay, IUI kara lo. Now let's have a look at this. A multicentric study was done, and what they found was with 1 follicle, IUI, IVF, no difference. But the moment there are 2 follicles, look at the success rate of IVF. So whenever there are 2 or more follicles, you should go in for an IVF. And the success rate is dependent on age. Always remember that for older women. Here again, if you look, 1, 2, and 3 follicles were compared, and they did find that you could undergo a transfer. But the conclusion was that IVF compared with IUI presents a superior pregnancy rate in the setting of 2 or more follicles. So always 2 or more. What about abandoning? She's made only 1 or 2 follicles. You say, abhi chhod do, next cycle stimulate karenge. Look at this. Proceed to IVF. Biochemical pregnancy rate and ongoing pregnancy rate is this much. If you abandon and try in the next cycle, it's still the same. So please do that cycle. Don't let it go. Whether it's 1 follicle, 2 follicles, just go ahead and do it. Lastly, the protocols, whether antagonist, agonist, dual stimulation, conventional, mild, natural, or PPOS. So this I'm going to deal with the IFS guidelines, because we did extensive research. And how did we do the extensive research? We took out 21,000 records identified from database. After duplicates were removed, 5,800. Then the records were screened, and based on the we removed the case reports, case series, educational response, language not relevant, and we ended up with 228. And then we excluded all the articles which individual articles which were in the meta-analysis. We took only the meta-analysis and we excluded the studies, because otherwise we would be duplicating their data. So we excluded those, and we got 116 articles for final review. So this was what we did, and it was a humongous task. I think many Zoom meetings, probably 87 Zoom meetings, about 180 hours of meetings, and I would say salute my team that they were very good, and the guidelines are because of the team. So just going over the guidelines on what they have said: pre-stimulation management of poor responders. Does hormonal testing at baseline have any value? Ultrasound imaging? Yes, and a strong recommendation. Does genetic polymorphism testing and immunological testing? Not recommended, and a strong recommendation. Immunological testing, there was no evidence, and hence we made it strong that there is no evidence, so it is not recommended. Estradiol pre-treatment or OCP pre-treatment, again not recommended. With estradiol, we made it conditional, leaving it to the clinician to decide. But with the OCP, definitely strongly not recommended. Does antioxidant pre-treatment improve efficacy, alternative medicine, and lifestyle-based therapies? Not recommended. But here, look, the lifestyle-based therapies, there was no evidence. So we made it conditional, because lifestyle-based therapies are always good. There may be no evidence. We can't recommend it on the basis of evidence, but we are saying that please go ahead with the lifestyles. Now, coming to the ovarian stimulation protocol, is GnRH antagonist protocol superior to agonist protocol for poor responders? Equally recommended, and this was a strong recommendation. Is mild ovarian stimulation protocol superior? Well, mild stimulation, low dose gonadotropin, and conventional stimulation are equally recommended. Now, remember, in mild stimulation, in all these sections, you will see that it is only recommended if the gonadotrophin is there, either alone or with clomiphene or with letrozole. And these are strong recommendations. This was a section I did myself, so I know that there was very strong evidence. Mild stimulation with oral letrozole and low dose gonadotrophin, oral clomiphene, again with low dose gonadotrophin, is equally recommended. That means that their effect was equal to that of a conventional stimulation. Now, coming to the decision to use clomiphene citrate alone as a mild stimulation strategy, if you look at it, this is dependent on patient characteristics and previous treatment. We did have 1 or 2 papers on it, but not very strong. And we realized that supposing a patient is 42 and she has only 1 antral follicle count, then why not give her clomiphene? Or in the previous treatment response, she had only 1 oocyte. So these are the patients we left for good practice points that clinician has to decide whether she wants to give only clomiphene or go on for conventional. With letrozole alone, there was no recommendation. GnRH agonist flare protocol not recommended. Duostim not recommended. Why not recommended? Because we do not know the impact it is going, long-term impact it is going to have. There were no studies on risk stratification. And the same was with luteal phase. We did not recommend it because again, there were no adverse effect studies, no randomized control trials which addressed adverse effects. Modified natural cycle, not recommended. Progesterone primed, again, not recommended. Again, only because we do not have the adverse impact on the baby of all these treatments. We cannot put them in guidelines and say we recommend them without that. Recombinant FSS compared to urinary gonadotrophins in poor responders, equally recommended. HMG and recombinant FSH, equally recommended, and this was a strong recommendation. Mid-cycle HMG, again, conditional, recommended. What should be the starting dose? Increasing the dose beyond standard was not recommended. Just standard dose, that is 300 and not more. LH plus FSH compared to recombinant recommended because there were a lot of strong papers, but we still made it a conditional because many clinicians felt that, maybe their recombinant FSH is enough. Early mid-cycle initiation of recombinant LH, equally recommended. What is this? What about the long-acting FSH? Again, equally recommended. Enough studies have come out to say that it is safe and it is a good drug to take and strong recommendation. Adjuvant, growth hormone, testosterone, DHEA, coenzyme Q10, glucocorticoids, not recommended. Again, no safety data. There is no safety data of any study about on the baby, otherwise. What about monitoring the stimulation? Yes, additional hormonal monitoring other than ultrasound, not recommended, conditional because there was no data. Criteria for conversion to intrauterine, not recommended. Again, conditional because data was less. Criteria for triggering of final oocyte maturation, which is the preferred drug, both were equally recommended, dual as well as conventional, because there were no randomized control trials for this condition. Does elective freeze-all? Not recommended. Follicular flushing, routine ICSI, PGTA or IVM, again not recommended and strong recommendations. Lastly, ovarian rejuvenation in the form of platelet-rich stem cell in vitro activation, not recommended and strong recommendations because of lack of data. So can we help ovarian rejuvenation, stem cells and PRP? Well, these are all experimental studies. Ovary back on the red carpet is what we have to aim for and not do these experimental procedures. One of the secrets of life is to make stepping stones out of stumbling blocks, and POR is a stumbling block for us. Thank you.
Thank you so much. Thank you, Dr. Subin. You were so good, so crisp.
Thank you.
Very thorough. And the best part was that today only I read these and I mean, I really looked at it. इतनी अच्छी guidelines बनाई है.
बहुत मेहनत की थी हमने.
बहुत अच्छी बनाई है. Congratulations to all the team members who really spared their time and made these guidelines just like ASHRAE guidelines. I loved it. 2-3 things is very, very important. One is LH में क्या हम शुरू में ही HMG ऐड कर सकते हैं या 5वें दिन इंस्टेड ऑफ लाइक रिकॉम्बिनेंट LH, बिकॉज LH तो आना बंद हो गया है, तो या तो हम कॉम्बिनेशन यूज करें, दैट इज ओनली वन एंड दैट्स वेरी वेरी कॉस्टली. सो फॉर LH कैन बी यूज HMG ऑन day 5 or from day 1? This is one question. And I mean, I want the answer for audience also, a very clear cut answer that we start in these very, very low AMH group, low AFC group. Should we start FSH plus HMG on day 1 or day 5, seeing the response of the FSH? So that is one question I want to ask. Second, if the patient is on antagonist cycle of this group only, which she is having only 0.2, 0.3 AMH and we are going for antagonist cycle. So should we trigger this patient with only SCG or with dual trigger? These two questions important.
So there are two things. See, if I'm addressing a second question first. If I'm going to do a fresh transfer, I don't use an agonist. I will go for HCG, and often with these poor responders, we do a fresh transfer. If I'm not doing a fresh transfer, I always give a dual. I always feel कि अगर वो work नहीं करेगा तो ये कर जाएगा. So I always give a dual for a poor responder because I would take everything into picture. Second is HMG is a very good idea, especially for a woman who has not responded earlier to the stimulation in the last cycle. HMG must be added. HMG or LHO right from the beginning. And I often do add HMG as it is, half HMG, half recombinant is my practice. I don't go fully to HMG because HMG is very variable in its,
batch to batch.
Sometimes it looks, you're giving 300, but it responds as 150, and sometimes it responds as 450. So I don't trust HMG to that extent. So that's why I always add a recombinant and I give an HMG for the LH. And to bring the
very clear and crisp message to the audience that for a trigger in these low AFC, low MH group, poor ovarian responders group, we can give dual trigger or maybe just SCG. And सबसे ज्यादा important जो है वो ये कि इवन एसटी गाइडलाइंस भी अब यही कह रही है कि यदि आपका पुअर ओवेरियन रिजर्व पेशेंट है देन ट्रिगर इन द do the stimulation in the same cycle and transfer in the same cycle. Do not do freeze for all. In these patients, we can transfer the embryos in the same cycle. And it's just SCG which can be given. And second, because now recombinant LH is not available in the market, so we can add HMG, purest form of HMG. And
give Pergoveris, but that's also very expensive.
Yeah, I'm giving, but that's also very, very costly. And you cannot give to each and every patient. So,
especially a poor responder where you might do 2-3 cycles,
Yes.
So that's the first thing we must look at is cost for these kind of patients.
Yes. So I was just coming on that also. Egg pooling of eggs is also very, very good option for these patients. Like by dual stimulation कह लीजिए, कुछ भी कह लीजिए, pooling of eggs is also.
I am routinely doing pooling. When they come, I tell them.
I am doing and we are getting results. यदि pregnancy आ रही है तो बहुत important है.
Somebody had very nicely put it in one of the international conferences. He says, when a patient comes for cancer therapy, everybody will say that आपको ना 6 cycle chemotherapy के चाहिए होंगे, और वो बंदा कुछ नहीं बोलता है, वो 6 कराता है. So why don't we tell them that multi-cycle is going to be needed for you? You need 2-3 cycles right in the beginning. We should tell them. And I started doing it.
Yes.
I started telling them. I said, आप बोलोगे तो मैं एक कर दूंगी, but you will actually require 2-3.
Yes.
Nicely said, Dr. Sumit. Nice revision. And you were right that if I have to be transferred, HCG is the best, and use dual. You never know whether HCG will work or agonist will work. So the same practice we have done. But if you are happy with one HMG and you're not changing again and again, I see that the results are equal. I have not seen that recombinant and recombinant.
So when I use, supposing it's a poor patient and I use only HMG for that patient, then I always use a higher dose.
Yes.
Because I feel that ये 300 act नहीं करेगा as 300. That is what I feel.
So how high do you go on that?
I add 75 more to it.
Yes.
Sometimes 150 also. 150 also.
450.
I'm a slightly higher dose person. I always feel
And
that.
then slowly I add some GH also.
Yeah, GH makes a difference if you have those smaller
Yes,
molecules lying
it
and they're
does.
not
You
responding.
know, number it doesn't affect. The quality is affected. You can see that.
Number also it affects.
What I've seen is quality is really good. Yeah, perivitaline space and the cytoplasm. It's really good.
Thank you so much, ma'am.
Thank you.
Ma'am.
Any more queries? Or we can move ahead with the last, but definitely not the session of today.
There's a
move ahead.
in the chat
Dr.
box.
Surveen covered everything. Very, very comprehensive talk. And I think she has covered, Dr. Divya.
Yeah, she has covered almost all the part of a panel discussion.
No, you'll get more things to discuss in the panel. This is an unending topic.
So, all the questions,
And
all
it
the
has
case scenarios.
made our work so easy.
So, thank you, Surveen ma'am. Thank you so much for this extensive, exhaustive talk of yours. It was definitely very enlightening. Now we move ahead with the next session of today, which is a panel discussion on posidal
I just
patients.
wanted to ask a question, Dr. Sureen, is this guideline available at our website?
Yes, it is there.
Yes,
just type in the guideline.
Yeah.
Indian Fertility Society POR guidelines. It has been published also in the IFS Journal of Global Health, and it is available on our website. Everything, all details.
Yeah, it is available. 100 pages, more than 100 pages.
All the files of excluded studies and other things, they are separate. They are separate files. They're lying of everything which we did.
It is available on the internet. I had shown.
Yeah. Even I have seen.
Thank you.
Yeah,
but the
research journal also.
What is it? The voice is echoing. Everybody is feeling that the voice is echoing.
Ma'am, my voice is echoing?
No,
yours is okay.
Whoever is speaking, the voice is echoing.
I think we can move forward.
Okay, ma'am, then we move to the third session. And I take the honor to invite the moderator for the session, Dr. P.K. Saxena, ma'am. She's the director, professor, and in charge of assisted reproductive services at Department of Obs and Gynae, Lady Hardin Medical College. She's also the convener of this IFS SIG Reproductive Endocrinology. Welcome, ma'am. Our second moderator is none other than the Secretary UP IFS East Chapter, Dr. Divya, ma'am. Dr. Divya, ma'am, she's the director of Ayushman Multi-Speciality Hospital and Nekisky Morpheus Akriti IVF Center, Varanasi. Welcome, ma'am. Now I request the esteemed moderators to kindly introduce and welcome the panelists.
So Dr. Shweta Gupta, she's the director IVF Max Super Speciality Hospital in Delhi and Noida. And she's also the honorary secretary of the Indian Fertility Society. Dr. Vardha, you have got the control, yeah. We welcome Dr. Leena Vadva. She is director professor, now not in ESI, but in CAFIMS. She is the head of the department of CAFIMS. And I'm sure she's going to build up an excellent center there. And she's also the editor of the Indian Fertility Society. Next.
Dr. Rashmi.
Dr. Rashmi Sharma, welcome Dr. Rashmi. She is she used to be the web editor of the Indian Fertility Society, and I think she has done a marvelous job putting up all those videos and upgrading the IFS website. It was really great. And she's also the convener of SIG TB in IFS, and she's recipient of several awards. And she's also the director of the Origin Fertility and IVF Center. Dr. Ruchika Goel. She is Assistant Professor, SRM, SIMS, Bareilly. Welcome, Dr. Ruchika. Dr.
Thank you,
Aarti
ma'am.
Kapoor is the co-convener of SIG Reproductive Endocrinology. Welcome, Dr. Aarti. Dr. Pallavi Dhawan. She's the director of Dhawan Medical Center, consultant, Tender Palm Super Speciality Hospital in Lucknow. Dr. Neelam Mishra, she's the scientific director and senior consultant at Vanch Clinic and Test Tube Baby Center. Welcome, Dr. Neelam. Dr. Aanchal Garg, she's the director, chief fertility and IVF and fertility center at Lucknow. Dr. Shipra. Dr. Shipra, I have the pleasure because she used to be my senior resident at Lady Hardinge Medical College. Nice to see you here, Dr. Shipra. And
Thank
she's
you, ma'am.
medical director at Dr. Bachi's IVF Center, Lucknow.
Thank you, ma'am. Thank you.
Is that all, Dr. Vardha?
Dr.
Yeah,
Shivali
Dr.
is there.
Shivali Tripathi. She's senior consultant, Opus Hospital, Varanasi. Welcome, Dr. Shivali. Dr. Kirti Singh is the medical director and consultant at the Vita Nova Fertility and IVF Center.
Last
but not the least, welcome Dr. Sonal Anand. She's the medical director, Blossom Women's Health and Fertility Center.
Now, ma'am, you can start your screen sharing. I'll stop the screen sharing.
Yeah. So,
thank you, ma'am.
sharing. Arno? Hello?
Yeah, Dr. Picky, you are audible.
Okay, so I'll proceed. We are going across through the same panel, which we have just heard Dr. Surveen. So we will hurry up because we have short over time. And Poseidon patients, are we stimulating smarter? So now we are doing ICOS, that is individualizing therapy in controlled ovarian stimulation. And ovarian stimulation as a response, as told by Dr. Surveen, depends on three parameters. The fourth, that is the number of follicles recruited as compared to the baseline antral follicle count. The number of oocytes retrieved, which is a measure of follicle to oocyte index, and then the quality of oocytes and embryos obtained during the controlled ovarian stimulation. The clinical goal, of course, is to obtain at least one euploid embryo, which will lead to live birth. And all the factors which are responsible for the response to the treatment in controlled ovarian stimulation are most important, as we have discussed, is age, then BMI, antral follicular count, AMH, number of follicles stimulated. So historically, poor ovarian reserve lacked a uniform definition, and a systematic review reported at least 41 different definitions across 47 randomized controlled trials. The result was that there was poor comparability, and therefore in 2011, the Bologna criteria of poor ovarian reserve was given. And if the patient had any two of the following features, she was labeled as poor ovarian reserve. These features were if the age was more than 40 or having another risk factor for poor ovarian reserve, if on oocyte retrieval, less than 3 oocytes were obtained with conventional stimulation, or if the woman had low AFC of less than 5 or low AMH between 0.5 to 1.1. But there was persistent heterogeneity and it did not consider age-related decline or help in clinical decision-making. And that is why the patient-oriented strategies encompassing individualized ovarian oocyte number criteria, that is our Poseidon criteria, was given. And this was shifting the focus from poor ovarian to poor risk prognosis concept. This was given in 2016. And as we have just discussed, it is based on the age, ovarian biomarkers, and number of oocytes retrieved. The first and the second group are both normal ovarian reserve, and the first one is less than 35 and the second one is more than 35. Both are having AFC of more than 5 and AMH more than 1.2. Again, they are subdivided based on group 1A, where there are less than 4 follicles which are retrieved, and group 1B, when 4 to 9 follicles are received. And group 3 and 4 both are poor ovarian reserve with low AMH and low AFC. And group 3 is less than 35 years and group 4 is more than 35 years. And the important point here to understand is in the younger age group, the quality of oocytes is good. The euploid embryo which we want to achieve will be obtained just by 4 to 7 oocytes. Whereas in older age group above 35, we need to have at least 12 oocytes in order to get one euploid embryo. And that is why the concept of pooling. So again, I'm not going to repeat the FORT and the FOI. And it is, if the normal FOI is, normal is set when the number of follicles which are retrieved during over pickup are more than 50%, and low FOI is if it is less than 50%. So coming to the case 1, it's a 28-year-old woman who presents with primary infertility for 5 years. Her ultrasound shows AFC of 4 to 5 on right side and 3 to 4 on the left side. AMH is 2.3, FSH and LH are both normal. She was stimulated with antagonist protocol and 150 international units were given, seeing her age, and only 3 oocytes were retrieved. Out of these, 2 fertilized, 1 fresh embryo transfer was done on day 5 with grade 1 blastocyst, but she failed to conceive. So any of the panelists can take up this question. What is the Poseidon category?
Yeah, Dr.
Poseidon criteria 1.
Belongs to category 1, that too 1A.
1A. 1A. So that's correct. Less than 35 years, adequate ovarian reserve, and less than 4. So this is the second case. Actually, the management of 1 and 2 are nearly similar, and 3 and 4 are similar. So we will take the management after case 2. So this was a case 2, 36-year-old lady, and AMH was 2.1. AFC was again good, 9 to 10. First IVF was given with antagonist protocol. Starting dose was 225 international units of recombinant FSH. And because of the hypo-response on day 5, this was changed to 150 IU of recombinant FSH along with 150 units of HMG. Trigger was given with triptorelin, 0.2 milligrams. 4 oocytes were retrieved, only 2 fertilized, and 1 blastocyst of poor quality was transferred, and there was no pregnancy. So what is this Poseidon category? Dr. Leena, Dr. Rashmi?
2A. 2A.
2A. Precisely. Correct.
2B.
So how will we match manage, what could be the possible causes for this? Poor response in an unexpected poor response in these two categories with good ovarian reserve. So,
They can be.
Dr. Leena?
Yeah, I think
In the
Yeah,
first
anyone can
case,
take.
in both the cases, we need to review the stimulation protocol. Like in the first case, she's a young patient with anticipated good response, and we got a poor response. And in that case, the starting dose of FSH was 150 IU. And so we have to keep and in the second case, you mentioned it was a suboptimal response, and maybe only GnRH agonist was used as a trigger. And to in addition, there could be asynchronous follicular development also that may have contributed to this poor response. And apart from that, we should keep in mind the
BMI also is unknown.
pardon.
Sorry, Dr. Ruchika?
Ma'am, BMI is also unknown in both the cases, so maybe the dose is not adequate. We are not
Yes.
sure.
Yes.
And also LH should have been added right from the beginning in second case.
Second case.
Yeah, because it's only FSH was used. And we see that patients who are older, they need LH right from the beginning.
So
how many
very
follicles are
correct.
there in the ultrasound, we have written the oocytes retrieved, but how many follicles were there and punctured? We have to see whether the enteral follicles is stimulated properly or not. Was it a retrieval problem? Was it a trigger problem, or was it a stimulation problem? So if there were enteral follicles and they were not stimulating, just 3 follicles were forming, then we have to think about either the drug is not working, there may be problems with the drug quality, or it is the patient whose follicles are not responding to the drug, which can be anything, receptor polymorphism or anything. But if follicles are forming, let's say there were 10 follicles and still 3 oocytes have been retrieved, then is it a problem of trigger, inadequate trigger, or is it a problem of retrieval? So the follicular chart is also very important, that how did the patient, how was the journey?
Yes, that's
Very,
important.
very important point. So Dr. Rashmi has very nicely enumerated that it is also the FORT and the FOI, both are important.
Yes.
How many mature follicles were there on the day of HCG? Because if mature follicles are there, then there is a technical issue. Either she is not taking the stimulation properly, or the inexperienced IVF consultant has not been able to retrieve, or the timing is incorrect. So all those things could be there. But as you have covered all the points, probably there may be gonadotrophin low dose could be there. So first time you are stimulating and her age is less. So you can start with 150, but you can increase the dose on day 5 if you find a hypo response. And you can maybe for the second cycle, you may add LH in the second case, because in the first case, it does not make sense. And asynchronous follicular development could be another cause, as Dr. Leena has said. So, which is the most common genetic polymorphism which is responsible for suboptimal response?
It is the
LH beta and
FSH receptor.
So in days, so do you recommend that all patients should be going for genetic testing?
No, ma'am.
No. So only when we are not getting adequate response, only then it is required, or we can increase the dose and see.
We can increase the dose, add LH.
Right. So what will be your approach in this case? Does the type of gonadotrophin use have an impact? What will you do for case 1 and what will you do for case 2? Dr. Leena?
For case 1, like in first stimulation, she had received 150 IU FSH. So maybe we can switch to 225 starting dose of FSH. And in the next case, she's elderly, I'll prefer to add LH since beginning. Maybe we can use injection recombinant FSH plus LH since beginning also in the second case. And a dual.
And if on 225 you get a hypo response on day 5, you can again step up the FSH dose and maybe add LH or HMG. So
yes. LH also.
Yes. So I just want to ask the panelists, do you use HMG instead of RLH? Because in public sector institutes, cost is a limiting factor, and we prefer to use HMG. What is your
HMG?
HMG.
But to use HMG, not the recombinant LH. Definitely. And we'd like to start with 300 in the first and second case, both. On higher dose.
300. Actually, you, as Dr. Surveen said, you can increase in an increment of 50 and see how the follicles are coming up instead of going straight away to
We should
300. In poor ovarian reserve category 3 and 4, or in more than 35 years age group, okay, maybe you can. But you have to, Dr. Rashmi emphasized that we have to see how the response of follicles is coming up and see the previous response also. And based on that, what does the panel say? What is the opinion of the others?
I feel even in the first case, starting with 300, maybe better. See, because these days we are just not worried about ovarian hyperstimulation syndrome at all. And it has been proven that every oocyte retrieved increases the pregnancy chances. And if there is a receptor polymorphism, increasing the dose is the answer. So, if you're not worried about getting too many oocytes or getting hyperstimulation, it is, what is the harm in using 300? It is said that beyond 300, it doesn't work, going to 450 or 600, that's definitely not advisable. But once the patient has suffered from a poor response, I feel in practice, I would agree with
Dr. Rashmi, in all cases, you are giving the starting dose of 300 because unexpected response may come in any.
Yeah. In this case, like in the first case, even if she's young, even if her AMH is fine, but her first cycle has shown that she responded very poorly, miserably, and failed. So in such a case, rather than starting with 225, I would like to add 300 straight away, because if, say, let's say hyper response this time, beyond our expectation, maybe everything is fine this time, and we always have agonist trigger, we can always prevent ovarian hyperstimulation. These days we are not worried with hyperstimulation at all. So yeah, that is
Yeah.
You can consider
I also agree with that, because 225 dose will be good for a expected hyper responder. But if a patient is a expected normal responder, we can start very well with the 300 IU.
And explain
And what is your opinion?
She's not a normal responder.
What is your opinion of starting with HMG in these cases?
Before this thing, like she came out to be a hyper responder, but with the reports and the AMH and age was likely she will respond properly. So we can start with 300 also.
Regarding the HMG, ma'am, like in the first case also, maybe I would like
to start with HMG also, ma'am.
Yes.
25 FSH plus 75 HMG.
Yes, combination.
A combination can also be added.
2:1 ratio of HMG and FSH and HMG can be started, or RL recombinant LH if it is if the patient can afford, because batch to batch consistency will be there.
Yes.
Although HTA guidelines, as Dr. Surveen showed the IFS guideline, they say that recombinant FSH and HMG are equivalent, equally. Recombinant, basically, they say that all there is insufficient data and scientific evidence to favor one type of gonadotrophin over the other, and the decision is subject to the availability, convenience, and cost. This is what we discussed earlier. So that is what they say. Although I feel that if the patient is not responding and the patient can afford, it is better to give recombinant FSH.
Yes.
And HMG as what is the maximum dose you are giving during stimulation? Any of the
600, 300 IU, ma'am.
300 IU is the
giving more than 300, 450 or 450.
450 sometimes.
450 sometimes.
is rare.
Not more than 450.
Depending on
Not more than.
BMI also. That depends on the BMI also.
Yes, that's a very important point. If she's obese or she has hyperinsulinism, maybe she may need a higher dose. If the follicles are not coming up during stimulation, would you like to increase, like in this case, would you like to increase the dose of FSH, or you would like to add LH or HMG?
Add LH. Add LH. Add LH.
So,
HMG can be
It will be better to increase the dose and
HMG.
Poseidon 2 and 4. Adding LH is going to give us benefit.
In older patients, it is definitely good. Otherwise, also we can increase the dose and give it in the ratio of 2:1 if the patient is not having adequate response on day 5. So this was a big study, worldwide survey done in 45 countries, 196 centers, and 1,24,700 cycles. And what they found was that 85% of the world clinicians, IVF specialists, were giving dose more than 300, and it was also exceeding 600 international units. So there has been this Cochrane review on individualized gonadotrophin dose selection, and they have recommended because actually in poor ovarian reserve, the recruitable follicles are few. So even if you increase the dose beyond 300, it is not going to increase the clinical pregnancy or the live pregnancy rate. So it is recommended not to go beyond 300, but I think till 450, many people are still giving, and it shows good results. Some of the papers are showing good results. So, and the other important point is, as you all have pointed out, the follicular recruitment starts in the luteal follicular transition. So best is to start as early as possible. So probably if you want to increase the dose next time, start it from day 2 only rather than waiting till day 5. And the role of LH supplementation?
It has definitely.
Anybody?
If the patient is of increased than 36 years, or if there's a hyporesponse in previous cycle or some polymorphism we are suspecting, we can add LH in such cases.
Yeah. So these there was this meta-analysis by Hill in 2012, which showed that addition of recombinant LH in these cycles can improve outcome in advanced maternal age. And another Cochrane review mentions that on addition of LH, higher pregnancy rates were seen in a small subset. It's not advisable to increase add LH in all. So in poor responders, LH acts by increasing androgens. So it improves the response of FSH. And if you see on day 5 or 7, the follicles are not adequately stimulated, then again you can add. And in older patients, as you have all said, the endogenous LH activity is much lower. So you can again add. And of course, in endogenous LH is deficient, so you need to add. So coming to synchronization, which is another factor seen often in the IVF cycles. So I would like to ask the panelists, what is the role of OCPs, progestogen, cestradiol, or GnRH, agonist or antagonist? Are you using any of these?
OCP not to be used.
What about OCPs?
No,
No,
should not be used.
OCP sometimes may cause very oversuppression, but for sometimes we can use it for a shorter duration, like 10 to 15 days only.
I think in practical,
generally,
OCPs, ma'am, should not be used because they lead to oversuppression. And
that is what is the evidence is saying, but using for a short while, it is not harmful, and we do use it in
for a shorter
practice.
duration.
Yeah, for shorter
Ma'am,
duration.
just to add to it, ma'am, just to add to it, for OCPs, a recent 2025 publication had suggested that OCP use in type 1 Poseidon criteria was helpful in achieving better oocyte numbers and better cumulative pregnancy rate. This was recently published in 2025 in British Medical Journal, and they had done a retrospective study. So they said in category 1 OCPs can
younger
be
patients
given, but
OCP is
remaining
going to help. And in the older patients, the estradiol priming is, I think, more important.
More useful.
Yes, in remaining 3, they did not advocate for it, but in type 1, they advocated for OCP pre-treatment.
Yeah, this is what is going with our clinical practice also. For a short while, you can give OCs, although in most of the studies have shown that it depresses the reserve further. So, GnRH agonist, again, same problem. It has proven efficacy. It synchronizes the follicles, but again, you will have to use much higher doses for a longer time, increases the cost. So the most viable action is, what is the estrogen that you are using? Are you using estradiol valerate from day 23?
Yes.
Valerate or hemihydrate?
Valerate, yeah, both.
1
2 milligram BD.
Yes.
Day 1 of
Anybody who is using ANTAG for synchronization?
If we don't have much time for the separation, then we can use it for a 3 to 5
Dr.
days
Shipra,
also.
have you used in your practice?
Yes, ma'am. Yes, ma'am.
Does
I
it
have used.
give a good result?
Yeah. On
Because-
day 2, we had a better, pool, antral follicle pool.
So the evidence says this is database 701 women, and this is only a low and moderate level evidence. So again, they say that COC's pretreatment was associated with lower rate of live births and ongoing pregnancy, tends to determine whether rates of live birth or ongoing pregnancy were influenced by pretreatment with either of the 3: progestogens, estrogens, and COCs. Progestogen treatment and OCs, they have said that you can use in case there are ovarian cysts or in agonist cycle. So again, this is what SRA guidelines also say, that the estrogen or progestogen is probably not recommended, and they acknowledge that estrogen or progestogen is widely used for scheduling purposes. OCs, again, they have not recommended, and GnRH antagonists, again, they have not recommended. So more evidence will be coming soon. So what is the role of PGTA? Would you like to do in both the cases that we discussed?
No, ma'am. Not at all. Less than 38 years, PGTA does not improve live birth rate. And now that we have such small number of blastocysts,
Yes.
it can be useful, I think, in Poseidon 4.
That is the very important message. No need to waste time and money and the precious embryos for doing PGTA. It is only recommended for older age group women, because otherwise it has shown to decrease the live births. Anyway, the euploid embryos are less, and we should not waste them here. So I will stop sharing now, and it is Dr. Divya, you can carry on.
Yeah, sure.
Thank you. We had an excellent interaction. Thanks to all the panelists for giving wonderful inputs.
Yeah, so coming to the next case, that
Dr.
is
Divya, make it a slideshow, please.
yeah, sure. Yeah. Is it visible?
Yes, yes.
So for case 3, will come this 30-year female with 4 years of infertility. Her AMH is 0.7 nanogram and EFC is 4. Day 2 FH is 9.5 and LH is 4. And she has already taken one IUI cycle with ovulation induction that was unsuccessful. Now the patient has visited the center. She has been advised for IVF. So we all agree this comes in Poseidon group 3. Yeah. So I would like to ask the panelists, how would you manage now? How should we proceed?
The first role of
IVF is definitely justifiable in her case. I
Yeah.
would also suggest her IVF because she's very young. She's just 30. Her chances are extremely bright, and it has already been 4 years. And if IUI has been done in her case, then I assume that maybe it is either an unexplained infertility or a mild male factor infertility. Then only the IUI must have been done. So in that case, definitely. Otherwise, also the IVF is indicated.
Yeah. The rest of the part has already been covered, like increasing the FSH dose and addition of LH supplementation. And so I just want to cover, so is there any role of duo stimulation in this patient? Because the AMH is already low and we are having the lower enteral follicle count. So should we go for DUM? Already it has part has been covered by Dr. Sirvin.
Yeah. As per the guidelines, we should not.
We
should. Yes. But if there is time constraint, as Dr. Surveen said, then we can go for dual stim.
Time constraint is
the embryo pooling is a good.
Embryo pooling can be done in this patient.
It is better option compared to this.
We have to ask the patient, what is her family desire? Does she want one child in life or does she want 2 children in life?
Yes.
If she says she wants 2 children in life, that means she should be going for embryo pooling. Because if she conceives in the first cycle, she will not be able to undergo IVF 2 years later, because the eggs would have already finished. So if she goes for embryo pooling and says that she wants to accumulate embryos, then yes, dual stimulation or bi-stimulation, either way, may be planned.
And the most important thing in this case, which differed from the group 4, that although the quantity is low, but the chances is quite high because of the high quality, because of the
low younger age group.
Which is good. So dual stimulation has already been covered. We all know about it. So although if we go for dual stimulation and we compare the data, the formation of fibroid blastocyst rate is almost same in both the phase. Either we go for follicular phase or luteal phase. The rest part, the stimulation has been done. Now the trigger part is very important. So I would like the panelists, how would you like to trigger the cycles of this poor ovarian reserve? Would you like to go for SCG or dual trigger, double trigger?
With HCG and with
If you are planning for fresh transfer, then can go for HCG, otherwise dual trigger.
So if the number of eggs are less than 10, then I would prefer dual trigger, even if we are going for a fresh embryo transfer, because agonist trigger, it has been seen along with HCG, definitely improves the M2 oocyte rate. It definitely improves the oocyte maturity because of the inherent FSH surge that it gives.
Yeah.
Also, agonist now has been proven as a very good luteal phase support. So if we read the studies in the Cochrane on the luteal phase support, adding GnRH agonist to the luteal phase improves the pregnancy rate, proven now. So, my choice would be always to go for a dual trigger to take advantage of both HCG and agonist per se.
Yes, it's a very important point because it causes both FSH as well as LH, right?
Yes.
And that is very important for the maturation also.
Yeah, maturation.
I would just like to
Yeah, Dr. Leena, you wanted to add something?
like Dr. Rashmi said, there's an advantage of giving dual trigger with GnRH agonist. And now the concept is coming up that even in GnRH agonist cycle, you can trigger with addition of FSH. Recombinant FSH can be added as a trigger because it gives that additional benefit of oocyte maturity. So dual trigger is preferable.
What should be the dose of FSH in that case? If we are going along with for the trigger purpose. Yes.
That is co-trigger. That's co-trigger. If you're talking about a hypogonadotrophic patient where you are not able to take advantage of the agonist trigger, then in along with HCG, we can add 300 IU of FSH, as Dr. Leena said, because that FSH is helping the oocyte to mature. So this is in cases where you are not able to use agonist trigger, either in an agonist cycle or in cases of hypogonadotrophic. It can be a co-trigger.
GnRH agonist helps because of the FSH surge.
Yeah, that's a very important point you have quoted. Yes. So what's normally the gap between the trigger to oocyte retrieval normally you follow?
35 to 36 hours.
36 hours.
I think it's same in with all the
I
patients.
would be worried
In
at
case of poor
36.
ovarian reserve. Yeah.
36 hours.
I would be worried at 36 because there are so
35
many
is good
mistakes.
enough.
So 35,
35.
34, 35.
35.
I think 34 to 30, 35 is quite.
35
35 is
quite
the
safe.
most commonly used in
So we all know that we are also, that is double trigger. I just wanted to know the opinion about the double trigger also. We all know that dual trigger and double trigger, they appears to be same, but there is a difference. In cases of double trigger, the GnRH agonist is given prior to SCG, they are
Yes.
not given at the same time. While in cases of dual trigger, both the GnRH agonist as well as the SCG are given at the same time, and both are found to be effective, but the studies are more with the dual trigger rather than the double trigger, and they have found to be effective by overcoming impairment of follicular function, oocyte meiotic maturation, and cumulus expansion. And this is the article, very recent article, which was published in May 2025. And they've shown that it increases the number of retrieved oocytes and potentially improves the reproductive outcome compared to conventional SCG trigger in cases of this poor response. And in the same way, this double trigger has also been found effective rather than SCG trigger. So now coming to adjuvant, which is one of the very important part of this poor ovarian reserve. So Dr. Pallavi, want to comment something on this adjuvant, androgens?
Though they are talked about much, but practically also we keep on giving these androgens. DHEAs shows some role with increasing the androgens, thus increasing the receptivity of the FSH over the follicles. And coenzyme Q is being used because it improves the mitochondrial function. The thing is that we should at least start 2 or 3 months prior to before giving the stimulation. Then only we see the results. Otherwise, just giving it together will not work. So it is just like a practical thing. If you want to give, you can, or you can try directly.
Definitely.
Opinion differs from gynecologist to gynecologist.
Yeah. Androgens have found to be effective in enhancing the follicle recruitment as well as enhancing the function, and they are critical for follicular development and granulosa cells proliferation. It augments the expression of the FSH receptors and enhances the ovarian response to gonadotropin. That is also a very important point. And there's a meta-analysis which included 17 RCTs, and they have seen that they've concluded that DHA compared to placebo, they have been found to be effective in increasing the live birth rate. In the same way, testosterone is also found to be effective in increasing the live birth rate when compared to placebo. So this is testosterone. It has been found to enhance the follicular sensitivity as well as improve folliculogenesis.
Yeah, Dr. Divya, just to add on now, there's a recent Cochrane review which Dr. Sureen also pointed out, which says that adding testosterone is effective. You can add testosterone patches or testosterone gel starting from maybe day 24 of previous
Day 21. Day 21.
And it has found to improve clinical pregnancy rates, but DHA is still inconclusive.
Yeah. So role of the growth hormone.
So that was actually discussed by Dr. Surveen very well. So though the evidence is not there, but yeah, it depends on clinician to clinician.
Yeah. It has found to be improving the reproductive this outcome, like increases the number of collected oocytes, increases fertilization, transferred embryos, but they have not found to be effective in increasing the live birth rate. That is very important.
Anyone of the panelists is using growth hormone?
Yes, I'm using.
I'm not.
In case
Dr.
of
Rashmi, when do you use and what is the dose that you're using?
Day one of the stimulation.
Yeah.
Along with the gonadotropins, I add 4 international unit of growth hormones subcutaneously till the day of trigger.
I also used previously, but nowadays actually there was scarcity of growth hormone in between, so I have I used to then leave it.
So Rashmi, you have found to be effective growth hormone?
Yes, ma'am. I found the quality definitely improves. Pregnancy rates are better. Number doesn't improve of the oocyte. We have to take into account the financial cost also, because around 10 days of growth hormone, 4 units cost something about 17,000, which is beyond the, you have to take the financial capacity of the patient as well.
Since by the studies, it is like plus minus thing. So we give a choice to the patient whether they would like to use or not, especially in the previous failure patient. I don't use it in the first IVF itself. No.
Sometimes the stagnant, follicles, they actually start growing.
Yes.
That
And
too for
some
age
people are
25
using
plus,
till
I
day
think.
24. Day 24 se leke, they are continuing till
there
day
are
of
studies.
trigger.
There are studies.
So different doses have
yes
and different schedules are also there. Response for non-responders in terms of increased number of follicles and the quality also.
Yes.
Dr. Neeta
So,
Singh is
Dr.
using.
Vitti, you want to comment something on antioxidant? She's not there.
Sorry?
Dr. Neelam?
Antioxidants mainly, if patient is deficient in anything like iron and all, then we can give. Otherwise, I don't think, other than CoQ, nothing is much helpful. Like we have to see the what is the status of the patient. What if she is having anemia, megaloblastic anemia, you improve that. Otherwise, just CoQ is, we are giving it quite frequently, and I feel it improves the quality of oocyte.
Yes, so this is a recent update, and that was this article was published in Human Reproduction Update and in year 2020, and that included 19 trials, and they have shown that DHEA, CoQ10, and growth hormone showed better clinical outcome in terms of achieving pregnancy and the lower doses of gonadotropins. And again, this is another article which has a systemic review and meta-analysis. Again, they have found that the DHEA, CoQ10, and growth hormone most effective adjuvants for improving the pregnancy outcome. And out of this, CoQ10 had the strongest association with the improved live birth rate. But when we go to ESHRE, they do not recommend any of these. They do not recommend use of testosterone. They do not recommend DHEA or the growth hormone for during the ovarian stimulation. They are not recommending it.
Ma'am, I feel practically.
Even I feel it is not very effective, Dr. Divya. Because initially,
CoQ10, I think helps in improving the quality.
Yeah,
I just want to know the view of other panelists.
Ma'am, practically, if patient is taking time in taking decision for IVF, let's say she's not decided to go ahead with IVF. She has 2-3 months. There is no harm in adding DHE and CoQ10.
Definitely.
But because of these antioxidants itself, IVF should not be delayed in a poor ovarian reserve. Like patient is ready today, go ahead with the IVF today because time is more important. This is what I feel. But
Yes,
if the patient is undecided, she wants to decide, take time, 1 month, 2 month, 3 month, there's no harm in adding CoQ10 and DHEA.
But DHEA should not be used for every patient. There has to be
only with the when the image in the
not
HC
just
are low.
pure. The young pure are not benefited by adding DHEA. Only the older patients, maybe more than 35 years of age, they may benefit. But younger patients, sometimes I've seen it does more harm than doing any good, because the number of
It
oocytes
is mainly recommended in low AMH cases only, DHEAs. So in that case,
Instead of using this DHEA, we can also go for testosterone gel. That is also because we can start almost 21 days prior to the IVF cycle. That will be effective in short time also. But DHEA will have to wait for at least 3 months before proceeding to IVF, at least for 3 months. So it's better to go for testosterone gel instead of DHEA. We do not have time in between. So the technique is also very important. Be in the ovarian reserve. So does the flushing during ovum pickup improves the outcome in women with this poor ovarian reserve? And how many of you follow this technique?
I do flushing routinely.
In all the patients or only in poor ovarian reserve?
Only poor reserve, where there are less than 4 follicles.
And you continue testosterone gel till when? When do you at least for 3 to?
Till the trigger.
Till trigger. Testosterone gel is given till the stimulation is
till
started.
the stimulation, yes.
Till the stimulation. No. So flushing you are using it, Dr. Rashmi?
Yes, ma'am. I'm using, though evidence I had tried to look all the time. It is very divided. And in fact, it says that flushing doesn't help. But there was this beautiful paper in 2-3 years back in one of the ESHRE, where in the same patient, in one ovary they did the flushing, in another ovary they did not do the flushing. And that was a beautiful paper in the same patient, both the ovaries being used as the controls, and they showed flushing, actually improved the oocyte recovery rate. I have been using it since 2013, and I feel, I mean, I have analyzed my data as well. I feel it helps.
I used in some patients, but later on, I experienced that the number of oocyte retrieval was not actually changed by doing the flushing. If I am able to see
We can think of using it only when we have got a very limited number of oocytes.
Yes.
Then
So
those patients we can,
sometimes, let's say there is just one follicle. So in the first tube, in the second tube, in the third tube, there is no oocyte. Then suddenly in the fourth tube of the flushing, the oocyte is retrieved. So if we have not done the flushing for that
patient
person, we would not have recruited that oocyte.
Yeah.
So many times, because we keep on asking, did you get the oocyte? Did you
very
get the
relative kind of, it's observation, but sometimes now in the poor ovarian patients, the follicles are empty. That is why the FOI is less. In these patients have a very low FOI sometimes. Those are sometimes only cyst only. So
I
the
want to ask
needs more studies actually.
And what the evidence say? This is a recent article. It is an Indian article, basically. They have found that there is increase in the number of oocytes, and also there is increase in implantation clinical pregnancy rate. But the live birth rate was not better with the flushing of the follicles. But most important, it increases the time of anesthesia and increases the time of the pickup. That is the main drawback associated with the flushing. So now coming to the last case, she's a 39 years married woman trying for last 3 to 4 years. AMH is 0.2, AFC 1 to 2 on both the sides. Semen analysis is normal, and she has never taken any treatment so far. So she comes in Poseidon group 4. So management, rest of the part is already discussed. Anything more to be added in this group?
Dual stimulation will be better for her if she wants to
Basically,
go for.
she is poor quality and poor quantity, so she has to be, she needs to be explained prior to her stimulation itself. And as previously, ma'am has also counseled that repeated cycles embryo pooling may be beneficial in this patient.
Yeah, the counseling is very
PGTA
important.
also. She
And we
needs
have to
PGTA also in this case.
Yeah. And the counseling is very important. We have to counsel the patient about the repeated IVF cycle. Also, we have to counsel about the oocyte donation, and we have to make them ready. If we do not get anything in spite of the 2-3 cycles, then she may need the oocyte donation. That is also very important part. And any role of ovarian rejuvenation, Dr. Rashmi, Dr. Leena, any of the panelists, do you want to comment on this?
It is totally experimental, though we do intraovarian PRP, and we also do intraovarian stem cell at the time of oocyte retrieval only, never as an independent procedure, thoroughly explaining and taking a consent that it is totally experimental technology. We don't know whether it will work or not. Because it is experimental, I never like to do the ovarian PRP as an independent procedure. But if a patient of poor reserve is undergoing oocyte retrieval, let's say she has got 1 or 2 eggs, we explain simultaneously that we take out the 1 or 2 eggs and then simultaneously inject PRP as well for future. This is what is my practice.
Did you see any or notice any benefit?
I have seen, ma'am.
This will not benefit. The effect will go away within 2 to 3 months. So, how if we are planning for a repeat IVF cycle immediately, then I think that would be helpful. But if we just leave it, then how will it be benefit? How it will be beneficial?
That is the preparation for the next cycle only.
And that is also like whether she would ever like to go for this thing or not. But and that's why it's not being done independently. Anyways, patient is getting anesthesia. Anyways, patient is getting invasive oocyte removal. So at that time, just adding on a little procedure for future, whether she would undergo IVF or whether whatever she would want to do it or not. This is what is my thinking.
We can also, if we are planning for the embryo pooling, what we have said, we can do the pickup and do the PRP installation, and later on it might be helpful in the next cycle when we are planning for the embryo.
If she decides.
And for the second cycle,
Yeah.
For the next subsequent cycle.
Subsequent cycle. So again, the
Ma'am,
stem cell therapy
Rashmi
short-
ma'am,
Yes.
for stem cell insemination, is there any ethical clearance required? I mean, are you doing some
I have done
ethical
just
clearance?
one. I have done just one, and that too for a very IS officer on her repeated request. And the ethical thing is the guidelines are that if you are doing from the same patient in the same sitting, you are not culturing in the same sitting, you are doing at the same place, not transferring the stem cell, it is okay. That is what the guidelines tell us. So for the same
Somewhere I had
patient,
read that according to the ICMR guidelines, stem cell is not permitted. Only in
Ma'am,
research
so-
settings it is permitted. You
Ma'am,
can
I
do
was-
ovarian PRP, but not stem cell.
Ma'am, I was very careful for this patient.
And
was
they
very
may or
repeated
may not
request.
work. And because there are a lot
Same sitting from the same patient without culturing, injecting at the same time, that is allowed.
Yes.
Ma'am, can you please elaborate once? How do you do it? I mean,
just expect exceptional patients. Only for exceptional cases you should do it. Otherwise, in this forum,
it's
not to be done for most of the patients. It is not indicated.
It is not
Actually, in nowadays, patients themselves are coming because they are reading a lot and getting suggestions from others.
Right.
Do PRP, do stem cell.
For stem cells, ethical clearance is required, and in that, the research ethical committee should have two stem cells. That's the guideline.
Yes.
Still, and one thing is more in experimental phase, that is in vitro activation, and it's need to become, might be in the future years we can see these type of process. So just to summarize, patients should be counseled early about realistic success rates, need for multiple IVF cycle. Individualized control ovarian stimulation should be based on age, image, AFC, and previous response. Doses should not more than 300 or 375 are really improve the outcome. Consider the LH supplementation, especially in age more than 35 years, previous poor responders, pre-stimulation strategy for follicular synchronization. Dual stimulation can be used for the oocyte accumulation. Add-ons like androgens, gonadal growth hormone, and DHEA, they are inconsistent evidence, but they may be promising. Stem cell PRP and in vitro activation for older this poor ovarian reserve may be a future. It is still in experimental phase. So donor oocyte adoption is the last resort. So just to summarize, in diminished ovarian reserve, success lies not in aggressive stimulation, but in intelligent individualization. And just to last, the key to success is smart work. So it's very important that if we deal the patient of all the Poseidon criteria and we stimulate it smartly, we can still get the success. Thank you.
Thank you very much.
Thank you.
Thank you, ma'am.
Dr. Picky and Dr. Divya for the.
Thank you so much.
Thank you. I think
Thank you,
it was a
ma'am.
very nice interactive session, and we learned a lot along with all the panelists.
Thank you.
Thank you, ma'am.
Nicely done.
And
I
thank
must
you for
congratulate
joining.
the team.
Thank you all the faculties for joining
Yeah.
and sparing your valuable time.
Thank you. And Divya, wonderful work.
Thank you, Divya.
Thank you.
Thank you, Dr. Picky.
Thank you, ma'am. Thank you, Dr.
Take a
Picky.
picture. Thank you, everyone, and a good night to all of you. Karan नहीं है कौन है Mukul, please take a picture.
Yeah, Mukul, please take a picture.
Yes, ma'am.
Thanks, everyone.
Thank you, everyone.
And we had very good attendance in this webinar. Almost it was there. 70.
Thanks, Dr. Varda, also for conducting the program so well. She's been our MOC. Thanks a lot. And
Thank you, ma'am, my honor. And I am formally rendering my vote of thanks. I am really grateful to each of you who attended this webinar on a weekday. And I thank the speakers, the delegates, the seniors, everybody, and also the backstage team, the IT team, Mukul, everyone for making this webinar a success. Thank you so much.
Thank you.
Thank
you.
you.
Good night.
Thank you.
Bye.
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 Thank you, ma'am. Thank you to all my seniors. Thank you.
Thank you, everyone. Bye.
Yeah, ji.